Welcome back. I'm Dr. Rahil here. In this short video, we will learn about mitral stenosis. But before we start, let's discuss a case scenario. We have a 68 years old lady who attended emergency department with history of shortness of breath and bilateral leg swellings for past 4 weeks. Her symptoms got worse recently and now she is unable to lie flat. The abnormal findings on physical examination included irregular pulse, presence of diastolic murmur at apex on auscultation, crackles at both lung bases, and reduced oxygen saturation and bilateral pedal edema. Based on the clinical presentation, what is the most likely diagnosis here? Please pause the video to go through the choices. The correct answer is mitral stenosis, and this takes us to the further discussion of mitral valve problems. First, we will start with mitral stenosis, which is a narrowing of the mitral valve orifice. Rheumatic fever is the commonest cause of mitral stenosis. Though it is rare in developed countries, rheumatic fever is still rampant in rest of the world. Rare causes include congenital deformity, annular calcification due to aging, and amyloidosis. Coming to pathophysiology, the normal mitral valve has an orifice area of about 4 cm square that permits free flow of blood from the left atrium into the left ventricle during diastole. As the valve area becomes smaller in mitral stenosis, there is restriction of flow between left atrium and left ventricle, and this causes increased pressure in the left atrium. This results in two primary pathophysiological consequences. Number one, increased left atrial pressure is referred to the lungs, resulting in pulmonary hypertension. And number two, decreased cardiac output. These effects of mitral stenosis produce a syndrome mimicking left heart failure. Common symptoms of mitral stenosis are shortness of breath, orthopnea, which is inability to lie flat, paroxysmal nocturnal dyspnea, and peripheral edema. Mitral stenosis is usually diagnosed when the characteristic diastolic murmur is heard on physical examination. This is a low-pitched, rumbling mid-diastolic murmur that is best heard at the apex with the patient in the left lateral position. The murmur precedes first heart sound, and the duration of murmur correlates with the severity of the stenosis. Associated signs include an irregular pulse, suggestive of atrial fibrillation, crepitations on lung auscultation, suggestive of left ventricular failure. The murmur sounds like this. Transthoracic echocardiography showing typical valve deformities is the definitive investigation of choice for diagnosis of mitral stenosis. Complications of mitral stenosis include atrial fibrillation, stroke, and infectoendocarditis. Mitral stenosis is considered severe if valve area is less than 1.5 cm square and gradient across the valve is more than 5 mm of mercury. Asymptomatic patients with severe disease usually do not require therapy. In symptomatic patients, medical therapy include diuretics like furosemide to reduce left atrial pressure. The definitive treatment is percutaneous balloon valvotomy. If mitral valve anatomy is not suitable for this procedure, patients should be considered for valve replacement, which can be a mechanical valve or a bioprosthetic one. And this concludes our discussion of mitral stenosis. Thank you for watching. In the next video, I will discuss mitral regurgitation.